I'm Dr. Rick Greene. It's a pleasure for me to host this series that's produced by our UVA Medical Alumni Association, which really highlights our wonderful emeritus faculty here at the University of Virginia. And it's truly my great pleasure today to be talking with Dr. Scott Jones, former chair of surgery here at University of Virginia. Scott, welcome.
Thank you. Thank you, Rick. It's a pleasure to be here.
So tell me, a Texan, I think you grew up in Dallas or were born in Dallas. How did a Texan get to Charlottesville?
Well, it was a fairly circuitous route, and it might take me a while to get it. I'll try to be brief. I was born in Dallas, but my home was I was raised in Tyler, and did all my schooling there in public school system. Went to junior college there, and then went to the University of Texas and to the University of Texas Medical Branch and interned there. But my departure from Texas was to go to Philadelphia, where I went on the advice of my mentor in medical school, who arranged me to go to the University of Pennsylvania in Philadelphia to be a surgical resident. And then from there, I went to Los Angeles to do a research fellowship in basic physiology. And my first real job was in San Francisco at the University of California and the San Francisco VA. I was in California for 4 years, and then I went to Durham, North Carolina to Duke, where I was on the faculty for 10 years before coming here to the university and started to work here in 1982. So that's how I happened to be in Virginia, and I was just following my interest in research, clinical care, and getting a better education and training, and I've enjoyed every minute of it.
I think you spent a few years working with Dr. Savastin, didn't you?
I did. I spent 10 years with David Savastin.
How did he influence your career?
Oh, immensely. It was maybe high points because I had a very busy clinical practice, but I also had a very active research laboratory there. I was funded by the VA and the NIH, and I worked with wonderful people. I had a joint appointment in physiology. I was a combination of a clinical surgeon and a basic scientist. And it was like being a kid in a candy store. I had a great clinical practice, and I had great opportunities to do research. We had great residents. And Dr. Savastin was incredibly supportive. It was very interesting. We didn't sit and talk. We didn't have any chats or anything like that. But he just arranged opportunities. One day I was in my office, and one of the people came to the door, opened the door, and they had a word processor. And actually, I was doing a lot of grant writing and paper writing and clinical notes and so forth. They brought it out, so I didn't order a word processor. They said no. I said, Dr. Savastin told us to bring this over here and install it. No discussion. So you don't have to have a lot of palaver if you have bilateral total commitment.
Excellent.
And that's what he and I had. Didn't have a lot of chit chat, but he was totally committed to me and I was totally committed to him, and it was a mutual understanding. So,
What was it about being a chair that enticed you? You came here as chair.
I did. And that was kind of a hard decision because actually I had pretty much the best job that somebody like me could ever have, because I could do everything I ever loved: look after sick patients and do research and work with residents and students. So that was sort of an interesting thing. I mean, in those days, I guess it was really something a lot of young academic surgeons aspired to do. And as it happened, I was beginning to being invited to do more and more administrative things at Duke, and I thought, well, I mean, I mean, I was kind of, they thought they wanted me to have me to do the chief of staff at the VA or one thing or another. And I thought, well, if I'm going to be doing more and more administrative things, I might as well go whole hog and be a chairman. And that's what I did. And I came here, and I continued to, or developed a practice. I couldn't live without being active, very active, and engaged in surgical care. But I devoted my energy to managing, developing the department of surgery here, and there were a lot of opportunities to do that. That was really a good thing. One thing I regretted about that, I gave up my laboratory research, and the reason I did that, my lab was actually, although it was funded by both VA and the NIH, it was physically present in the VA hospital. And so I moved away from my lab and from important resources. I'd just been funded for 5 years. But I just decided that I was going to help other people develop their research, and that's what I did. I worked with you're the person you just interviewed to develop laboratory facilities and resources, and we got that started, and that momentum has continued. It did throughout my time here, and then my successor, Irv Crone, has done just a fantastic job of continuing that development of clinically inspired research. So I'm really proud. I think I kind of got it going, but he really took it to the pinnacle. It's incredible.
Well, along these lines, what advice would you give today to a young academic surgeon starting as assistant professor who wants to do something along the lines that you've done? What are the things you would advise that person at this point, that things you've learned maybe the hard way?
Right. Well, I think from my own experience, my clinical research, and in those days, this is what we did. We, young surgeons, worked with basic scientists and learned how to be a basic scientist, and I did that. And I ended up doing a lot of research on things, learning new things physiologically, but it ultimately didn't have a lot of connection with clinical care. And I think opportunities now, I think what I would advise young people is to make sure that their research is closely integrated with what they're doing clinically, so that all your hours are spent. And so when you're doing clinical work, you're also doing research, and when you're doing research, you're also doing clinical work. And there are examples about how that works. My poster child for that concept is Craig Slingloff, who is a very distinguished professor here now. He started out doing very, very fundamental research in tumor immunology, looking at molecules. And he worked very closely with basic scientists and got all that. But then as he moved forward, he moved that scientific knowledge into the clinical realms. So what he started studying with molecules, he is now applying with clinical trials very successfully, and will change cancer care, hopefully in our lifetime. You're in mine. I think we're already beginning to see improvements in the care of malignant melanomas and other as a result of that. So that's what I'm talking about, and that's very relevant now in cancer care, endocrine care. Certainly, Irv Crone did this magnificently in cardiac and vascular care. So just that simple. Get your life organized so that when you're in the lab, you're doing things that are relevant clinically, and when you're in the operating room or the clinic, you're doing things related to your research.
Great advice.
Absolutely.
Let's talk a little about your transition from the operating room and from your academic career. What are you interested in? What gets you up in the morning?
I'll tell you, I retired.
You're actually using the word retired?
I did. What happened for my last few years here, when I stopped as chairman here, I stayed on the faculty, but I was very seriously involved as on the executive staff of the American College of Surgeons. And I got totally committed to clinical research, quality improvement, and safety, particularly quality improvement. And I made serious commitment to the initiation of a program at the college called the American College of Surgeons National Surgical Quality Improvement Program. That was started in the VA, but when I was on the executive staff, I had the pleasure and the challenge of taking that very successful program and working through the college to introduce that program into non-federal hospitals. And that has gone very, very well. So when I was doing that, I spent 4 years doing that. And we started with just some trials with 12 hospitals, and the system worked. And then we initiated the introduction of that program into hospitals. And by the time we had gotten it into 125 hospitals, non-federal hospitals, and it was working very successfully at reducing surgical morbidity and mortality. And I had reached an age where I thought I should get out, and I didn't have any more responsibilities here, and I wanted time with my family and with my wife. And so I retired from everything and went home and spent time with my wife, and we had a wonderful time together for a few years, and she died suddenly. And then I sort of looking around about what to do, and I really got interested in the Affordable Care Act and started studying that. I wanted to work on it. And after having been retired for about 7 years, Herb Crone invited me to come back on the faculty, which I did. And that's what I do. I do outcomes research, and I've studied data and data management and biostatistics and epidemiology and Lean and Six Sigma and healthcare policy to the extent that the university gave me a diploma in that.
And you're an official Wahoo now.
I'm an official Wahoo now. And I get up every morning, and my best time is in the morning in terms of thinking and writing and doing that. And I'm usually in my office somewhere between 6 and 7 o'clock every morning, sometimes earlier. And I spend my days my computer and reading and studying, and I have wonderful colleagues. I have people in the department that I had worked with previously, but my experience in graduate school put me in contact with biostatisticians, systems engineers, and other people. And we now have kind of an informal, collaborative group. Just yesterday, one of my partners and colleagues submitted an NIH grant that we're going to work on together to try to understand why there are disparities in surgical outcomes between African Americans and other racial groups. And and that's one thing we're working on. So I'm working on racial disparities. I'm also working on the implementation of value of surgical care using data, and I'm analyzing publicly available data from Medicare, and right now I'm working on. We just published about 2 weeks ago. We had published a paper where we had analyzed outcome data from Medicare hospitals, and we were able to quantitatively compare the value of different groups of hospitals in this country. Very interesting outcomes. And so I'm going forward with that, and we're we're looking at another year's worth of data to see how it compared. This Medicare value-based purchasing program is going to be very, very important, because for the first time, at least for Medicare hospitals, we have highly reliable, it's not perfect, but it's highly reliable data that grades the value that each one of these hospitals provided. And it's going to be a good thing for the American public.
Well, Dr. Jones, I don't think the word retirement
No.
should be in your lexicon.
No.
I
couldn't
don't
do
think
that.
it's part of your lexicon.
That was the worst failure of my life.
Well, you humbly alluded to your work with the American College of Surgeons. As a surgeon, I want to congratulate you for your leadership, your presidency of the American College of Surgeons, your work with NSQIP. I think it's up to 800 hospitals now
Yeah,
that have
about
NSQIP.
750.
So I want to publicly recognize you for all of that.
Yeah.
It's been an absolute pleasure for us to talk with Dr. Scott Jones today as part of our University of Virginia Medical Alumni series. Scott, thank you so much.
Thank you, Rick. It's a real pleasure to be here.
Thank you,
Thank
sir.
you.